Hello, I am Dr. Sanish. In this episode of Anesthesia Tools, let us discuss about AutoPEEP or Intrinsic PEEP. Normally, during passive exhalation, the lungs empty by elastic recoil, and at the end of exhalation, the alveolar pressure is the same as the atmospheric pressure. However, for several reasons, the lungs may not deflate fully before the next breath starts and the pressure remains elevated. When it arises inadvertently, as you see in the case of this gentleman in the video, it has been called AutoPEEP, occult PEEP, or intrinsic PEEP. Remember, the key pathophysiology here is expiratory flow limitation. Okay, now let us see who develops AutoPEEP. I have given three categories. First is dynamic hyperinflation with intrinsic expiratory flow limitation. The classic example is COPD patients. Second category belongs to dynamic hyperinflation without intrinsic expiratory flow limitation. This happens when your breathing pattern or ventilatory settings involve a rapid respiratory rate, high tidal volume, low IE ratio, end inspiratory pause, etc., or added flow resistance as it occurs with the narrow endotracheal tube, problems with ventilator tubings and devices, etc. And the third category is conditions without dynamic hyperinflation as it happens during recruitment of expiratory muscles. Let us see the consequences of AutoPEEP. Why are you worried about intrinsic PEEP? The first and foremost thing is increase in the work of breathing, which we will see in detail. Now have a close look at this diagram with baseline alveolar pressure, the pleural pressure and the airway pressure all at zero level or the atmospheric pressure level at the end of expiration. I am telling about a normal breathing, normal patient. Now what happens at the inspiration? The diaphragm and the inspiratory muscles contract and bring down the pleural pressure to say -5 as in this example. So this will be reflected inside the alveoli and alveolar pressure also drops to -5. And now there is a gradient from the airway pressure of atmospheric pressure 0 to -5 inside the alveoli and the air flows across the airway. This is what happens during inspiration. Our topic is AutoPEEP, and let's see what happens in a COPD patient with exacerbation having inadequate exhalation and developing some AutoPEEP, say 6 centimeters of water. Again, look at this diagram closely. At the end of expiration, because of inadequate exhalation, alveolar pressure is still plus 6 centimeters of water. A portion of it will be reflected in the pleural pressure also. So the pleural pressure is also plus 2. So during AutoPEEP, the intrathoracic pressure is kept on in the positive range. In the pleural pressure is still plus 2 at the end of expiration. Remember, the atmospheric pressure or the airway pressure is 0, and you can see a resistance across which the flow dynamics occur. Now the patient has to breathe in. So next, breathe in to create a pressure gradient across this resistance from this baseline 0. The alveolar pressure will have to be brought to a negative value, say -3. How is it possible? Because the inspiratory muscles will have to work hard to bring down the pleural pressure to say as much as -9 to bring down from +6. So this alveolar pressure has now with huge effort has become -3 centimeters of water. Yes, now there is a pressure gradient existing across this resistance and air flows in with this active inspiratory efforts. Now you can appreciate how much extra work of breathing has set in because of the AutoPEEP. Now we are bringing in CPAP or non-invasive ventilation to bring up the external PEEP to, say, for example, 6 centimeters of water. Again, you look at the dynamics at the end of expiration. The alveolar pressure is +6, pleural pressure is +2, but the airway pressure is +6 because we have given CPAP to this patient. So what happens during your next inspiration? From the +6 value with a minimal effort, say pleural pressure generated, say around 3 centimeters of water, the alveolar pressure has brought down to +3. Okay. Now even with this +3 alveolar pressure, there is a gradient from the airway pressure of +6. There is a pressure gradient driving airflow across the resistance, and the airflow happens much easier compared to the previous scenario. The other consequences include worsening of gas exchange. This is very important. Arterial oxygen tension was found to be lower in patients with intrinsic PEEP than in patients with a comparable level of external PEEP, an effect authors attributed to a less homogeneous distribution of AutoPEEP among the lung units, because different lung units will have different resistances, and there will be different AutoPEEP raised in different parts of the lung units. So it can also cause hemodynamic compromise and can lead to inappropriate treatment. Let's see how these things happen. So when you think about the hemodynamic effect, observe this picture very closely and look at the right heart and intrathoracic great veins. They are subjected to a positive pleural pressure throughout the respiratory cycle when intrinsic PEEP is there. PEEP, intrinsic as well as extrinsic, exerts its most powerful hemodynamic effects on the right side of the circulation. Normally, venous return to the heart is driven by the pressure gradient between the systemic veins, as estimated by mean systemic filling pressure, and the right atrium. PEEP increases the juxtacardiac right atrial pressure and decreases the gradient for venous return, and hence the cardiac output also comes down. In short, PEEP reduces the preload and increases the afterload for right ventricle, reduces both preload and afterload for the left ventricle. Elevation of pulmonary vascular resistance by the hyperinflation can unleash a vicious cycle of right ventricular failure. Importantly, volume loading will be deleterious in this scenario, as blood dams up in the failing right ventricle, which is unable to eject its large preload into the high resistance pulmonary circulation. Through the phenomenon of interventricular dependence, elevation of RV pressure impairs LV filling, further reducing the cardiac output. Let us see what dynamic airway collapse means. When the pressure of the alveolar gas exceeds the compression pressure of the small airways, as you can see here with air trapping, the airways are collapsed because at some regions it is not having a full cartilage support, so these airways are likely to collapse due to the outside pressure of the air trapping. So with each subsequent breath, more gas gets entrained into the alveoli and the alveolar pressure increases, contributing to further airway collapse. This is actually less important in severe asthmatics. Those small airways are muscular and resistant to compression. In contrast, in COPD patient, there is permanent destruction of the alveolar unit, and in these patients, dynamic collapse of the airways contributes more to the dynamic hyperinflation. This is how air trapping manifests with the flow time graph. You can appreciate a normal curve, and then this is what happens in, say, a COPD exacerbation. You can appreciate the deviation from the normal, from the expected normal tracing. The flow time graph is not touching back the baseline before the next inspiration happens at this point of time. So this gap shows air trapping or the building up of AutoPEEP. The important thing you can note here is during the subsequent breath, further air trapping happens, and this distance, the air trapping level, increases with subsequent breaths, worsening the workout breathing, impairing the oxygenation, etc. Here are some real monitoring interfaces for you. Again, you can look at the flow time graph and appreciate the air trapping. This is evident in both the interfaces shown in the picture. Let us now examine how external PEEP helps to treat AutoPEEP. Here is the classic analogy of waterfall. You can see the high alveolar pressure mapped here in this tracing, and then there is a narrow collapse segment. The upstream segment, the pressure is labeled as critical pressure. Okay, and the airway pressure here, let's say, is the atmospheric pressure. So during expiration, how it happens is it follows down the pressure gradient, and after the critical pressure there is a great gradient, and exhalation happens smoothly with each breath. Okay, now what we are going to do is we are going to elevate the base in pressure by instituting extrinsic PEEP. Say this is the new baseline pressure. Okay, I am going to increase further with say 2/3 of the critical pressure or the AutoPEEP. Now what happens during exhalation is still possible because it can drop down from this value to the new baseline, so there is no problem with exhalation. What is importantly happening is during inspiration, previously we needed to bring in from this low level to this high level during inspiration. Now that the baseline has increased, we can better ease of workout breathing. You can breathe in from a higher baseline. So this is the advantage of providing almost 2/3 of the intrinsic PEEP in your extrinsic PEEP or the CPAP settings. So how do you tackle or manage AutoPEEP? First, treat the problem, reduce the flow resistance, which is very important. These are the methods to tackle the flow resistance. Give bronchodilators, medical treatment, yes. Your airway devices should have adequate caliber, large bore endotracheal tube, and make sure the tube inner lumen is cleared of secretions. Any clogging of your devices with secretions will increase the airflow limitation further, so remove those. Next is to reduce the ventilatory demand, reduce anxiety, pain, fever, shivering, so that the carbon dioxide production or the load reduces and the requirement for breathing out comes down. Reduce the dead space, give sedatives or paralytics as and when required. If you are playing with your ventilator settings, these are the things you should keep in mind. Reduce the respiratory rate, bring down or target at normal breathing rate, decrease the tidal volume. In an effort to increase minute ventilation to wash out CO2, do not compromise on the expiratory time. Keep in mind that the set expiratory time should be at least 3 times the time constant to allow enough or adequate emptying of the lung units. Again, counterbalance the expiratory flow limitation by the application or institution of external PEEP or CPAP devices. Have you heard about the Lazarus phenomenon? It is described as a delayed ROSC, return of spontaneous circulation, after the cessation of cardiopulmonary resuscitation. This was first reported in the medical literature in 1982. The term was coined from the story of Lazarus, who was resurrected by the Christ 4 days after his death. More interesting aspects and topics in connection with the intrinsic PEEP may be discussed. I request you to go to my website www.onlineanesthesiatools.com. and find more description and references. The link will be given in the description below. So until we meet next time with an interesting topic, it's me, Dr. Sanish, signing off. Thank you and goodbye.